So tell me a little bit about your exam. So do for a primary patient who comes in surgery naive, they've able to see you, you're thinking, okay, this patient's here for nasal obstruction, maybe some drainage. We think this is, a sinus reason. What's part of your exam? Do you like rigid scopes for these patients? What's your enteroscopy like?
Right. Well, I'll back it up a little bit. I think my exam starts from just observing the patient to begin with, right? You can learn a lot about what's giving people trouble by their behavior and verbal and nonverbal cues and their family member who's in the room with them. Again, for quality of life disease, that's super important. The other thing is, many of these patients, if they have like loss of nasal tone in their voice, you can almost hear the nasal polyps before you look. Sometimes there are subtle differences and there's some facial asymmetry. One eye is a little bit proptotic and the patient never notices it. And if you're looking at them from a bit of an angle, you wouldn't notice it either. And so those things help. But beyond that, I mean, everybody gets an endoscopy. I use pretty much exclusively rigid scopes. I record almost all the exams onto our image archive that we have available, sometimes for just patient education, sometimes for checking progression. For me, it's more meaningful to look at the video from a prior visit than to read the description, that we have in the chart. And so we have that available for us for each encounter as well.
Do you like to decongest or spray?
Not routinely. I know I'm an outlier in that curve. I think, the sprays themselves are not super comfortable for patients. They taste bad, they cough and sputter, and the exam is super brief. The effect of the numbness in the throat sometimes is more discomforting than the, quick, 2-minute scope. But in polyp patients, they don't really feel much in the nose anyhow. And so in this patient group, it doesn't matter. I mean, spraying it's not going to add anything more.
Yeah, and sometimes like, the tip that it's polyps is when you try to spray their nose, everything just comes right back out.
There's no place for it to go.
It
Exactly.
just doesn't even go in. Anything else that you do in particular as far as, with your scope exam or any other physical exam?
I usually use a 30-degree telescope almost exclusively to start with, and then move up to a 45 or a 70 for frontal or maxillary views. But in a patient with polyps, it's a 30-degree scope. I've moved to using the 3 millimeter versus the 4. It's just a little bit more comfortable for patients, especially if you're not spraying. Again, that's not as much of an issue in polyp patients because they just tolerate more. But you can get a really good view with a 30-degree 3 millimeter scope hooked up to to standard office camera. And so that's sort of the workhorse now.
Yeah, that 1 millimeter really, like, even when like, if I've been using a 3 and then I use a 4 for whatever reason, like, suddenly I'm like, "Oh my gosh, it's huge."
So big.
Yeah, it's a huge difference. It's also interesting when you go down a notch too. The 2.7 so-called pediatric scopes are a lot more fragile. There's something about 3 that is sort of that magic sweet spot between a good image and good durability and just a better patient tolerance for it.
Yeah, that point 3 millimeters. That's crazy, right?
Yeah.
And what are you seeing on your scope exams in the nasal polyp patients?
So we try to categorize the type of polyp. Okay. And so a lot of that I think is hand waving and you kind of go back retrospectively and you can say, well, this is a neutrophilic polyp versus an eosinophilic polyp. But we try to make a pass at that. Sometimes you can get clues by the colors of the secretion. So if there's sort of that golden yellow crusting, that's going to be more eosinophilic. If your polyp is more hyperemic, that's going to give you a clue. I mean, sometimes I'll talk about, cystic polyps, which are sort of like grapes. They're just fluid filled, and other ones are more fleshy. All those things I think are helpful data points, but not in the instant in which you're doing the exam. You have to kind of collect the observations across time and then kind of put it together into something that makes sense. And the video, that's why recording the video is so helpful because allows you to do that pretty easily.
And as you're thinking about those different types of polyps, does that you mentioned that maybe not in the moment, it may not necessarily change treatment options at that time. You're saying that if as you look at it over time, that the type of polyps might dictate treatment options, at the second or third visit. Is that what you mean?
Basically, in particular, okay, so in Southeast Texas, most of the polyps are going to be eosinophilic. But occasionally, we'll have patients who we do all the usual things for, and they just do not do well. I'll go back and look at video from the OR, from in clinic, and then it'll be, oh, this is a neutrophilic polyp, and we just completely missed it, and it gets treated differently. And that's why, steroids don't seem the same way. It just is a different picture. But in a busy clinic, it can be difficult to realize that. And I think there's, kind of on a phenotypic level, there's a lot of overlap in how their endoscopies look at any one moment in time, right? So for those patients who are not doing well, I'll try to correlate, again, across time, what each treatment does and how their endoscopic appearance will changes across time. That's why the recording is helpful.
Yeah, for sure. The picture is worth more than 1,000 words for sure.
Right. Exactly.
And, like, with your hat of vice dean of clinical technology, do you see a role are we already using AI for some of this longitudinal endoscopy or imaging or videos in response to medications, and then fitting that with some of the immune, like, the type of are they responses or
I know there are companies looking at an AI endoscopy for sinusitis. They're mostly aimed, I think, at primary care docs, actually. So not really us. And so the idea is you have an AI algorithm reading an image that says, yes, this patient has sinus disease or not. That's really the limit of it. I mean, because the problem is doing an AI model for something that is your training data set. It's only as good as your training data set. And you would need thousands to be able to come across with this longitudinal kind of journey of what an endoscopy looks like. It's too much right now to do that.